But I'd like to welcome everyone and thank you for joining us today on this very timely and very important webinar to kick off our quality improvement series. This is the first webinar in a 5-part series. And as Caleb just let us know, this webinar is being recorded and will be posted to our website. And Caleb Lazinski will send that link out towards the end of the series, at the conclusion of the series, as a reminder of where those are located. My name is Kim Mayo, and I am a program specialist here at the DRCHSD program, which is providing this webinar today. And for all of you who've joined us, we'd love to know who's here with us. So utilize that chat box and let us know your name and your organization and your role there. That's very helpful to us. We encourage you to use that chat box for discussion, any questions that you may have, or if you're able, you can unmute your line and ask away that way. We love to see you and hear you as well. We do ask if you are not speaking, just to make double check and make sure you are on mute. That really just helps to cut down on any of that feedback. All right, the next slide is our just our funding statement, and we always put this on everything that we do. So we want to let you know that the DOSA program is funded by the Federal Office of Rural Health Policy in collaboration with the Delta Regional Authority. As you can see, we have several other dates and topics for this series. So they're all listed out there, and we're excited for all of those upcoming topics. And I want to let you know that ACHE credits are available for today's webinar. In order to gain those credits, Caleb will be sending an email shortly with a link that can be completed to get those credits. So ACHE credits are available for today's course. Before I introduce our speaker and turn things over to her, we do have some pre-polling questions that Caleb will launch. There you go. So a couple of questions here. So we'd like to know your how you feel about your understanding of how to build an internal quality department review. So you have some choices there: confident, somewhat confident, neutral, somewhat unconfident, and unconfident. And then secondly, we would like to know about your understanding of quality framework and committee structure. And again, those same choices for options there. All right, I'll let that run as I do our introduction. So we're very fortunate today to have Dr. Angie Charlet with us. She is a registered nurse with over 30 years experience in healthcare. She has a bachelor's degree in nursing and a dual master's degree in both healthcare administration and business administration, and a doctorate in business administration. She is certified in both Lean Six Sigma and a black belt in Six Sigma. She has over 12 years experience in rural health care, helping hospitals and clinics improve workflow and enhance quality outcomes and implement new service lines with their hospitals and clinics. So again, we're just thrilled to have Angie with us today. And I believe at this point you can start sharing your slides, Angie, and I'll turn it over to you.
Getting there now. Thank you so much for that introduction. So do we have the Canopy Quality 101 up? Is that what you guys are seeing?
Yes, that's what we see.
All right, perfect. All right, so what did our polling question results show? Because I missed that. Did it?
Can you see those? Are they shared with you?
They are.
Okay.
So somewhat confident, neutral, unconfident, unconfident. Okay, so this is good. So today is really basics. You guys will see, if you're watching the video, please pay attention to slides because I move my hands all the time. And I will apologize ahead of time because I've had this little tickle, so I have my cough drops with me. But today really is, let's just kind of go back to the basics. What we want to do is really kind of look at, what does quality really mean? You know, understanding the basics of our role as a quality director, looking at that internal department review. You know, when people say, oh, you work in quality, well, what does that mean? You know, it's how you really look at that department review and internalize it, but then externalize it to the community. And then we're going to look at some quality frameworks and committee structures as we go along. The chat box, please, please, please use it. You've seen that we have 4 other sessions coming up, the next one being on QAPI and your QAPI plan. That'll be a lot more detailed than this one is. But please, if there is a topic, an area of need, and we don't have it in our structure of webinars, let us know. We'll put it out there. We can do a pre-recording and send it to you, or I can work with you one-on-one. All right, so what we're going to look at: who, what, when, where, why, and how. You know, these are the basic questions of, you know, our quality. So the first part is, you know, the very boring and very tedious history lesson. So I do teach at a university part-time, and it's always fun to go through the history lesson and why is this important? And really, you know, we think about quality and where it started. And it really started as an industrial improvement. And even today, as we look at Six Sigma and Lean, that also came from the industry side of things, you know, and they really started to look at errors, you know, with Short really focusing on the telephone errors that they were having. And what he created was our well-known PDSA cycle, which we're going to talk about later. And then we had Deming, who really started to work with Ford, and the product, you know, what was it put out there, what types of testing were done, how did they know it was better quality? He really started to help in Japan and Toyota, building a 14-point quality framework, which we're not going to go into all those frameworks. If you guys want something like that, I do have a webinar I did on that a while back for the school, if you want to see some of those different ones. And then Duran, which we are very familiar with, and quality plan, improve and control. It's a 10-step performance improvement product. A lot of what we see in Duran is what we see in Six Sigma and in Lean. So how it all started. So let's think back. There was a couple of books that had come out. To Err is Human. It came out 1999-ish time frame by the IOM. Really felt the numbers were slightly inflated based on that report. And what they had attributed were 44,000 to 98,000 deaths related to healthcare errors. And it was the 8th leading cause of death through errors. And then in 2011, a new report was released, the Journal of Patient Safety, and they found the errors were from the systems around them, processes, conditions that led to mistakes, and failure to prevent them, you know, which is really what quality is all about, is how are we doing this to, you know, prevent the mistakes and follow specific processes. And then we had our 6 aims come out, crossing the quality chasm, you know, and this is what we're going to kind of dig into a little bit today. You know, it's really, you know, our aims for improving our healthcare quality. So we have our deeper 6 aim events. A lot of people think of this as STEEP, S-T-E-E-E-P. You can frame it any way you like. It's just a matter of what works in your head to remember it. But is it safe? You know, we want to avoid harm. You know, we still want to improve our outcomes, but we want to continually work on that improvement and enhancing the processes around us. You know, whether it's through our policies and procedures, you know, or through the actual practice of what we do. Is it effective? Are we making a difference? You know, looking at our diagnostic and testing services. Are we overusing, underusing? Chest x-rays was one that we had done some time ago. You know, are we overusing CT, overusing MRI? And is it patient focused? You know, are we really paying attention to what the patient needs and what the patient values? So, and then we look at timely. You know, are we avoiding our delays? Are we having a reduction in wait times? You know, this can be typically even in our ER, or waiting for test procedures, waiting for the results of those procedures. And efficient. I always think about lean when I think about, is it efficient? You know, it's that waste reduction, waste of time, waste of supplies, you know, really looking at, you know, the energy exuded to do a certain task, and what can we do differently. And then equitable, there's no discrimination. So through our history lesson, that we had learned from Deming, Duran, and Schuett, quality is not just a department. It is an entire organization. Everyone plays a role in quality, and this was learned through all three of those keynote authors. Quality improvement is that continuous study of adaptation of a healthcare organization's functions. I know this is a lot of words, but it's really, think continuous in its processes and its actions. It's actionable. It consists, the IOM has their definition there, consists of the degree to which healthcare services, increase the likelihood of a desired health outcome. Again, it's continuous. It has a process that improves our health outcomes, and it has actions to get there. And that's what we want to think about. So here's where we're going to start looking at, really looking at quality improvement, and what are we really doing in quality? So defining your quality improvement, when you ask your managers, one of the things I always tell new quality directors is to go around and talk to the other managers and then talk to the staff. What do you think quality is? How do we know we're doing the right thing? What is their perception of quality versus your perception of quality? And then how do we measure it? What gets measured gets done. So how do we do that? And then one of the things I find anytime I go in a hospital, especially doing mock surveys, are the consistencies. Are we consistent in what we do? Are we using evidence-based guidelines and practices? A lot of departments are notorious for having those evidence-based books that they use as their resource manuals being greater than 5 years of age. So again, are we in true time? Are we following regulatory guidance? Looking at if we are DNV, Joint Commission, certifications in our radiology or CAP or TJC and lab, are we following the regulatory guidance? Ongoing standards of practice. Do we have them, and have we updated them? There is nothing worse than doing a review of a department and they reviewed things and they didn't update. So you have 3 different years of reviews with no updates. To me, that's telling me that they really haven't done a detailed review of those standards of practice. And then the biggie is trending for outcomes. I love to ask staff, and I'm going to use some of my examples from mock surveys too as we do this. How do you know you're improving? You can tell me what you're measuring, but how do you know you're improving? Trending for outcomes and looking at what does this really look like? And then finding benchmarks. If we don't have some kind of a set standard, it's often hard to meet that benchmark. But even an internal set of expectations is needed. So a lot of times you'll see a graph later on. I try not to always say I want to be 100%. If I'm at 70%, I want to at least get to 85% and then 95%. And each quarter have incremental changes to get to success. If you set it at 100%, then why are you measuring it if you're already there? And those are things we're going to think about. So our foundation, what is the framework of our quality program? This also will be listed in your copy plan, but are we TQM, total quality management? CQI, continuous quality improvement? Are we PI, just performance improvement? Are we Six Sigma? Are we using DMAIC framework? Are we PDSA? Are we lean? What do we have as our set process for quality improvement and our goals? How are they written? How are they described in each department? And can anyone from any department understand that? We want to look at who our customer is. This doesn't mean just our external customers. This is also our providers, our employees in every department. We have internal and we have external. And how are we addressing that? Looking at the process. What is that process as we start to measure these quality improvement goals? And then, as always, show me the data. So we want to define the customer and that customer focus. Who's internal, who's external? How are we addressing their needs? Let's say I am lab and housekeeping is one of my internal customers. They come in and clean, and I have a very sloppy blood draw station, and they are always coming in contact with blood, needles, or something. Or my sharps containers are always extremely full, or, again, these are kind of, out there a little bit, but we want to think about, are we meeting their needs too, and addressing some of the challenges they have and the continuous complaints that they may have on the department or what might be happening, really that voice of the customer, what they want, but also then, how can we make that change? How do our customers define quality? I want to have better health. I want to have the results immediately, and what is their role in the framework of our quality program? And then how we show we are all together in this. This is truly a teamwork effort. And one of the things that I typically ask staff would be, what is their role in identifying quality? What is their role when we are measuring data? And how do they know their role? One of the things that when we get into our coffee plan next week is looking at, is it measurable, and does everybody understand the measurement so they know where the data is coming from to demonstrate improvement? Processes, these are the bones. When I think of processes, I think of that fishbone diagram, and you have all of your lines. So no matter what we do, it involves a standardized process and that methodology to completion. History has told us 85% of our problems can be traced back to a process. This goes way back 1999 and before that. In order to reduce the variation, we really have to look at the processes, the flow charts, the frameworks, and the direction. And one of the things I really want to point here is if you have flow charts in your processes and you updated equipment, did you update your flow charts? Is there a different step in the procedure? Do you reflect that new standard, that new piece of equipment, that new process in that flow chart or that framework and direction of what you are doing? Again, looking at those policies and procedures at the same time and addressing that. So we all know there is that QI model for improvement, and there's multiple ones out there. The IHI it truly is that standard model, uses those 3 questions as our baseline of framework. What are we trying to accomplish? How will we know that a change is an improvement? Not all change is an improvement, but change is change. And then what change can be made that will result in an improvement if we did not achieve where we wanted to go? And with that, IHI really focuses on that structure, process, and outcomes. So, and this is from another a little history lesson, Donovan model. But when we think about structure, think about capacity, systems, your processes to provide high quality care. Looking at the ratio of nurse to patient, number of providers you have. And some other areas we can think of are the use of EMRs, effectively. Are we documenting everything we should be doing? And then we have process measures, what a provider does to maintain or improve the health. This could be our percent of patients getting mammograms, colonoscopies. If you're part of an ACO, these are things you measure. Our diabetics are maintaining their A1Cs. The process measures really inform the consumers about the care they may get, what they can expect to receive from those providers, from that institution, and it can be for their chronic disease focused area, or just health outcomes specific. And then our outcome measures really reflect the impact that we had. What changes did we make? Our hospital acquired infections is an outcome measure. Death post-surgical cases, those are outcome measures. What did we do to reduce all of that? We think of our outcome measures as that gold standard. It's measuring specific areas that, that improve the health. A lot of times we started to see, especially probably maybe 2012 to 15 era, they really started to involve risk adjustment scores with our outcome measures. It's still evolving. They haven't totally defined those yet, but it is coming. And then we have our Plan, Do, Study, Act. Well known. We all know this. Plan, what are we doing? Are we setting our goals and the improvements? What in our do is carrying it out. Our study, analysis. And you're going to see this in your statement, your SOMs, that you have to have the analysis. And we're comparing data to maybe some predictions if we have them. And then act. What did we do to make a change? What did we do to sustain a change that we have been very pleased with? If you're using DMAIC, in Six Sigma, there's a define, measure, analyze, improve, and then control. The one thing I cannot stress enough is as you're evaluating your quality role and quality department, make sure you don't have too many models. This is one area that I really feel can get cumbersome. Hospitals have used PDSA, PDCA, for quite some time. And then they went through Lean training or Six Sigma training. And so now they're using DMAIC, but again, what are you using each framework for? I personally like to see PDSA, PDCA, as the basis for every department. And then when you start to look at your strategic plan or some special projects, some new innovative ideas, that you do that deeper dive and you use maybe some of those Six Sigma tools like DMAIC or some of the Lean tools, but you don't want to have too many, and you don't want staff to be confused about the model for your quality improvement. So when you're going around and you're looking at what you're doing in the hospital, you're the new quality director, you're kind of getting a feel for your role, but you're still kind of confused. Here's some things to look at. How is the hospital defined quality? What was in the original plan when your butt took that role? Basically, what did they define quality as? Do you have a definition? How is quality incorporated into your strategic plan? Ask for a copy of your strategic plan and look at that and say, okay, where does quality fit in alignment here? What is that QI process, your PDSA, PDCA, and then your departments? What are their efforts? One of the things we will learn next week is every department must have some form of quality improvement process. This includes IT, maintenance, all of those other departments that always say, well, we don't really have anything. Admitting, every department must have something, some effort to improve. And then can staff speak to it? Is the data displayed somewhere in the department? And then for those that have gone under Studer, we have our Studer pillars, and a lot of that will be put out in the hallways for our external customers to see. What is on our website? What have we put out there, to share with the community if they are evaluating us? We know we have to have something about quality on our website as mandatory. So what do we have? How do we explain quality improvement, our QAPI program to our customers? And then any specific QI projects that are house-wide or department specific. And what are you doing with those and how are they being reported? So quick refresher, we have quality assurance, quality improvement, and performance improvement. For those of us like me, you've been around a while, you've heard quality assurance forever. And these are the things that we want to think about when we think quality assurance versus quality improvement. And I use quality improvement and performance improvement interchangeably. To me, they really look at the same thing. So QA, think about it's reactive, doing things the right way. We're meeting specific targets. We're looking at process-focused actions. Our protocols, vent-acquired pneumonia is one, UTI, CAUTIs, readmissions is another. that can be a quality assurance type reactive review, looking at the compliance driven focused areas that we have to meet. And then don't confuse that with quality control, which is really looking at, our temperature checks and those kinds of things. And then we have quality improvement. How do we do it better? What can we do differently to improve? Or is there a new way out there? Is there new evidence-based practices out there that we can look at? Raising that bar on quality, looking at those new methods that are coming out, staying proactive, opioid reduction, more recently, antibiotic stewardship. Lean looks at waste reduction and how we can incorporate that. Chronic care management is a great quality improvement in how we engage our external customers to keep us as provider of choice and how we're working with them. So we're going to talk to some departments and we're going to reevaluate our current quality department. A lot of times you're a department of one and you don't just wear a quality hat, you wear multiple hats. So you really want to look at, okay, how do I gather this information collectively? So when you are talking with your different managers, here's some of those musts. Every department must have a quality improvement project. What is it? How is it reported? And we're going to talk about that in a minute. How are they collecting the data? Does the staff get involved in the data collection? The one thing that I really try to hone in on, especially with managers, is you don't want the managers collecting all the data because the staff may not then realize what data is being collected, how it's being collected, why it's being collected, and where the data goes. So you want to understand all of those basic questions: who, what, when, where, why, and how. When we think about EDTC, I'm going to use this one through MB-Quit. So we have our emergency department transfer collection that we are looking at. If the manager is collecting all of that data, the staff may not understand all of the areas they're missing or what's happening with that data. And one of the things I used to like to share when I was with a network of hospitals was have some of your ER night nurses especially review some records, print out the paper form and have them review some of those records. It starts to identify areas of opportunity and areas that are being monitored by someone else, so that they really start to get a feel for what is being looked at in our quality improvement. So your department process, we hear often, what do I measure? I don't know. Ask them, what's that pain point? What is staff's challenge? The frustrating areas for staff. Are you measuring the same thing year over year? If you are, why? If you are measuring something year over year because you have to, is it really quality improvement or is it more quality assurance now? Does it make sense? When you start asking your managers what they're measuring, ask them how they came up with that idea. What was the need at that time? Are they trending consistently at 100%? If they are, 4 quarters to 2 years, they've been measuring this, they have been at 100%. Have they truly drilled down to the right problem? If they still feel they have an area of opportunity, dig deeper, and really start to look at the process. One of the things I like to do is, show me the data, but then follow the trail. Start just writing out the entire process, follow it all the way through and look at, okay, where is our pain point? Well, it's over here, not over here, and really start to target another area for that opportunity. Do we have numerators and denominators? And are we graphing and demonstrating our trends? That is something that we definitely want to have so we can show our trends upward or downward, and we can talk to it with staff at our department meetings. So again, use all of these on these slides, make yourself a checklist and talk to different managers. If you have a new manager coming in, these are great points to have, as looking at, how to help them understand quality. Are they using SMART goals? Have you educated managers on SMART goals? Is it specific? Is it measurable? Is it attainable? Is it relevant? And is it time-based? It's very simplistic, and that can be part of your PDSA cycle. And I'm using that one as our framework, that in our PDSA, we have all SMART goals written out by our managers, by our departments, and you can have a template for them to help them to, achieve that success. One of the things that I used to have staff, notoriously say, I didn't know it went to the board. I didn't know they had to approve what we were doing. Does staff understand where the data is going? It just doesn't go to a quality committee. It actually goes all the way up, and your board of managers, board of leaders, whatever, your directors, they are ultimately responsible, and then how often does that go up through the board? So when we think about that, we also want to say, okay, how often is it going to committee? But then how often are managers meeting with their senior leader to evaluate and review the data? Is it quarterly? Is it as needed? And what are they doing? So when we think about, what's happening with our data, and I've touched on this, where are we? Where are we to goal? How do you address poor performance in quality improvement? When we think about that, we've got someone that is consistently at 80%. They are just not getting up where they need to be. They're not even, doing any kind of a trend of any sort. What can we do differently to help educate them and to help educate staff? Are we engaging the medical directors in specific departments to look at the data? And then are we changing our data routinely? So this, I know it's hard to see when you guys get your slides, you can blow this up. This is a tool I had at another hospital. It was actually a PPS hospital. And I do want to touch on this hospital because I can share it now. It was Galesburg Cottage Hospital here in Galesburg, Illinois, and they got closed. They recently, I want to say 4 months ago, were closed because of Joint Commission because of quality of care outcomes. And, they did not perform to meet the expectations. And, it's really sad to see some of those things happening. And this was a tool that we had back in the day. It was not there when when they had closed. They had since changed ownership, but it was a great tool. So this is based on IDEA. So we have an improvement, we have data, and then we have our determining of our causes, and then we're going to explore solutions and make actions. So what it does, and this is an Excel file, and it shows what's our goal. What is the opportunity? Why did we select this goal? That data collection methodology. So anybody from the staff can go and collect the data. And this is important, especially if you have somebody that ends up on FMLA and no one else knew where the data went. So, and then it automatically will trend the graphs for you. You plug in your numerator denominator and it'll automatically trend it. Now this one's set at 100% as our target goal, but again, it gives you a look at how you can improve. As you determine your causes, that findings and analysis of your data, you have to quarterly explain it. Here's my data, here's where I'm at. I am not reaching my goals, or I am reaching my goals. And then what have you identified as the issue? What do you need to do differently to make the next quarter better? Do you need to re-educate? Do you need to continue, as you are going? And there is nothing worse than seeing, continue as planned. Well, continue as planned, but re-emphasize it with staff. Continue as planned, identifying potential new opportunities. You want to have something actionable in there, on what's being done, that action to improve. Maybe you're changing who's going to do it, how it's going to be done, or when it's going to be done. Maybe we're going to change from monthly data collection to weekly data collection to improve the process and ensure we are, meeting our targets. And then we want to know when and where. So again, where's the data going? Does staff understand where the data is going? So have a spreadsheet, and these are things to look at as your role in quality of, okay, where's the data going and who's it going to? So I have all of my departments listed each quarter when they're going to submit their data per month. And then here's where all the data goes. Here's my flow chart of all of my committees. Now, again, this one's a little bit bigger and more robust than what we typically see in our, critical access hospitals, because a lot of our committees are combined. But again, it gives us an idea of where the data is going and how it flows up. But then also, how does it flow back down? If it went to the quality committee, was it approved? Did they ask questions that we need to then ask our staff about in our departments? What can we do differently, to demonstrate this smooth communication process? But everything that goes up also must come down, and we want to know that. We want to know what was being asked, said, or shared, moving forward. So we're going to go through our quality department review. And one of the things I do have, along with the slide deck, again, it's just a Word doc. It's a tool as a gap analysis to help you do that quality department review. You can muck it up all you want. It is in a Word document for that reason. So you can add or change anything you like to meet your hospital specific areas. So there's basically 3 areas I like to think of when I'm doing a quality department review: that management and leadership, your performance measurement, that improvement process, and patient safety. And these are pulled right off of CPHQ as well. When we look at what are they, really stressing on versus what we really want to focus on as well. So we have a quality plan. You as the quality director are likely responsible for completing that quality plan. But please remember, it is a team approach. And there should be a way to systematically follow the overall strategic plan with your quality plan, and they really complement each other. So when we think about our plan, who is going to help you? What's in your plan? Does it make sense? When is your plan reviewed and by whom is it reviewed? Where does it go? Understanding its purpose, and then how are you disseminating it to staff? So are you talking at new employee orientation? When a plan is approved, do you send a copy to every manager so that they have it to review with all of their staff? Thinking about, what we do in our plans, we really want to disseminate that education piece. A lot of us use Policy Tracker or Policy Tech or one of those to update all of our policies. And, a lot of times we review them very quickly and we forget it. Versus if every department has a copy of the overall hospital quality plan and their embedded area is listed in that plan. So how they actually, rank up into the plan, how are they affecting it? So everybody knows that they have a role to play. So management and leadership. When we think about this, we really want to think about, our role in quality and our vision and mission of quality, not just the organizational one, but our quality and quality department specific. What data is being analyzed? Do we have a scorecard? Do we have a dashboard? What is visual in the department? So where is it located? I love to see them on boards in departments. That linkage to our strategic plan. One area I do not really touch on, but are there any financial benefits? And that is something that we definitely look at. If we are Studerized, we look at our finances. And if we are Six Sigma, we look at the financial benefits. And then benchmarks. Are there benchmarks out there by department or, again, globally as a hospital? Our performance improvement. Again, evidence-based practices, our guidelines. If we have policies and procedures, are we updating them? Are we updating our resources in manuals to demonstrate that these are evidence-based practices? If we have certain protocols we follow for CHF, COPD, pneumonia, our catheters, again, what are we using and is it, up to date? What measures are quality assurance, reactive focused versus quality improvement and proactive focused? How do we train and educate all staff? I cannot say that enough. You know, is it part of our LMS system to touch on this on an annual basis? New employee orientation. What are our regulatory requirements and when are they due? You know, when are they coming? And it's not just the overall Joint Commission DNB, it's some specifics in our hospital, in radiology, in dietary, you know, in even maintenance has some regulatory requirements. And then those ongoing improvement actions. One of the things we want to look at in our role as quality is what happens when we meet goal. You know, how long do we want them to sustain that goal before we stop measuring consistently and then we spot check versus, you know, remain under that goal. Again, these are just some of those questions that you're going to want to ask yourself as you are reviewing your department. And then patient safety. How are we embedded in patient safety? What does that look like? Do we have patient safety specific goals, national patient safety goals? You know, are we evaluating them? Are we evaluating our equipment and technology? Do we need to change anything with that? Do we have our root cause analysis process? And how do we determine when we need to do an RCA? And then those team-driven processes that we implement, or some hospital-wide teams versus department teams, and what those look like and how we address it and, you know, incorporate patient safety with that. So then let's switch goals or gears just for a minute and really looking at data analytics and rural health. This is often, you know, can get confusing and it can get monotonous when we start looking at data, you know, and then your eyes just kind of go bug-eyed when you look at Excel files. So, but data is really at every point of what we do. It can be through our patient demographic intake, patient care, compliance, billing, regulatory requirements. We have multiple areas that we receive data from. So, but when we talk about the impact, you know, we really want to talk about, you know, is it a byproduct of our workflows, our operational efficiencies, you know, the impact to patient experience, our HCAHPS data, and then if we're doing any department specific CAHPS type surveys, and then looking at patterns and trends. You don't have to be a data analysis expert to look at this, but you really want to make sure that your managers have a good understanding of how to evaluate their data, how to analyze their data, you know, and how do they know they need to drill down further, you know, when they are looking at the data. And then, you know, the flip side is our external customers. How are we reflecting our data, you know, to our external customers? What does it mean to them? You know, when we talk about data and we talk about that connectivity of the quality of care we provide, we want to be the provider of choice for our community, both primary and secondary if possible. And then we want to connect to our providers. So again, you know, docs love data, you know, so if we can pull data from our EHRs, what does that look like? You know, really equipping them with data and comparatives from similar organizations, if we have that, you know, availability, you know, looking at mortality rates for patients with heart attacks, it can be one measure, but let's go back one and say, okay, maybe it's door to transfer, you know, when we think about, you know, the level of quality that we are providing. So, and that was with the OP3, our troponin testing. Most troponin test protocols were within 60 minutes or less. Now, this has been a couple of years old. You know, the ideal was at that time, 35 minutes or less. Our data is demonstrating we are 45 minutes. We are more than half taking longer than expected. You know, 25 minutes could be, you know, just getting the ambulance there to get them there. And then they have to wait an additional 25 minutes where we could have had them in and out the door, you know, to further enhance what we are doing in our quality and looking at the data. It wasn't our mortality rates. It was looking at how quickly are we getting the tests done, you know, and that operational efficiency to improve patient care outcomes, you know, and we really want to use that thorough use of data analytics, you know, to optimize what we are doing with our patients and really looking at, you know, how we improve overall structure and organization. So So that is all of my presentation. I kept it just at 50 minutes, so I have a couple minutes for questions and answers. So with that, I would really like to open up for questions, challenges, and struggles that everybody may have.
Thank you so much, Angie, for that great material. Yeah, now's your opportunity. Feel free to use that chat box or unmute your line and ask away.
And there's quite a few people on here that I recognize name-wise, and I promise I won't call you out on this.
Yeah, while we're waiting, we can go ahead and do that post polling question.
Okay.
So now we have an opportunity to answer these questions. So again, we just want to know your understanding of how to build an internal quality department review. And then secondly, just about your understanding of a quality framework and committee structure.
And I am curious as to everybody's framework, if they know. If you could pipe in, to the chat box. I assume, a true assumption, majority of hospitals still use PDCA. If somebody's using something different, type it in, or type in that's what you're using. I'd be really curious, to see how in what you are using. Everybody's quiet.
Yeah.
The other area that I do like to, look at, somewhat confident. It's scary, isn't it? When you think about that internal quality department review. One of the areas, when we think about our folks is really looking at, how do we truly internalize this with our managers and have them build it? Joanna says she uses SQSS. So, yep, I've seen a lot of people using that. And they have this built into their QIPI. And I like that. Is that the one from Darlene? I think SQSS is Darlene's. Darlene Bainbridge, but I couldn't remember. PDCA. Yep. Yeah. So all right, I'm going to give you guys a little funny here. So back in the day, there were two things I said I would never do. One was quality and one was finance. So my doctorate's in business, go figure. And I teach a lot in quality now. My first quality instructor was Darlene Bainbridge in the hospital. So she's been around a while, a lot of fun. And she has a really nice product to look at, on how you are changing and converting to that. So there's another product out there. There's a couple others out there really looking at how you can build in the reporting cycle of your departments. Looking at, okay, here's all of my departments reporting, and it goes to their senior leader and then on to the quality person for the committee structure, and it really kind of helps align communication overall. If you are using LEM, a lot of folks use the LEM through Studer, to really embed some of that, structure and communication. You are implementing PDSA. Now, if you guys want anything, if you're new to PDSA or PDCA and you want a little bit more training on that, give me a shout. We can do something like that, or just holler at me offline and say, hey, Angie, I just want a little bit of help. Can you review this? That's what I'm here for. I work collaboratively with the National Rural Health Resource Center. There's tons of information out there, but if you guys want just a quick eyes on something and say, does this make sense? And if a reviewer were to look at this, would it make sense? We can do that. You're not out here alone. We are all in it together.
Yes, you are a great resource, Angie, and we appreciate that greatly. And she means it, folks. She really does. I know she does. Her heart's in it.
Now, if anybody happens to be from Missouri on here, I am having a conversation with Missouri on Friday. Oh, that's tomorrow. on what we can bring as far as a quality workshop. So if there's something you guys want, hey, speak up and I'll bring it up now. And I can bring it up tomorrow. So, but yeah, I am here to help. I, really looking at, how we can make this 5-part series robust and fun. I do have some other friends in the networks that do a lot of Six Sigma training. If you guys want something like that, I teach some of it, but I mean, he teaches it continuously and has a better framework with the Sigma boards, the MAIC boards. But again, I'm here to help and connect you with people. Yeah, the slides are going to be sent to you, I'm assuming, Kim, and
Yes.
the checklist, the gap analysis tool.
Yes, we'll make sure all that gets, yes, out to everyone.
Okay.
For sure.
So, and then one of the things that I've done in the past is a mock survey, and how a mock survey fits, in evaluating your quality. That's something we could do as well. Would love to get a hospital that would let me come in and just kind of video a little bit of pieces without patients. Having Darlene do a workshop on SQSS. Ooh, that's a good idea. So does she do many workshops anymore? I'm not sure how much she's doing, but you could ask. I know her daughter does a lot with her as well. Oh, perfect.
There you go, Joanna.
Any other questions, needs, pain points, frustrations?
Looks like here is a question for the group. Has anyone else had an issue completing an ER throughput project for the year? Our throughput times have become completely out of reach due to bed availability, COVID. I'm struggling.
Hey, everybody. Again, we're a team. We're here to help each other. And I can't remember, is there anybody else on too, Kim, from the National Health Resource Center? I think there are some throughput best practices somewhere on your guys' page, but I can't remember where. So we definitely want to get out there as well.
Mm-hmm.
And throughput, that is just ugly. Yeah. And getting them out of the ER. I know, I will share, one hospital opened a triage, like a temporary bed placement area, where the patients were admitted as OBS, and they were held, and was at that hospital, it was right next to their surgery because they had closed surgery, and they used that as, for bed availability. And then as beds opened up, they started moving them into the general floor. But that was one area, and that they had done because of COVID. I don't know if it's still in practice now as COVID has started to decline, but it was somewhat innovative in utilizing a suite that was no longer being used at the time.
Hey, Janet, and I'm linking a request to our implementation technical assistance request, and it's a very easy form, online form to complete. And if there is any, specific, anything specific that we from the center can provide and can help with that, with that issue, we'll be glad to do that. And so, I do know that we are working with an organization currently in a cohort to look through their throughput project. So it's definitely something we can support. So, yes, feel free to grab that link and complete that. And we from the center will be happy to discuss that further with you.
Anybody else? Questions? thoughts, needs?
Yeah. Quiet group.
Yeah, that's all
Great.
right. This one doesn't tend to bring a lot of questions. The next ones I know are gonna have a little bit more.
Yeah. Absolutely. And we're so tickled to start this, this foundation to get this started. And we can't wait for next week when we will be discussing and managing your coffee program. So we're excited for that. That's next Thursday, same time, same location. So we're excited to see you all there. And we appreciate you all joining us today. We appreciate you very much, Angie, for sharing your knowledge and expertise with us. And we wish you all just a great day, great rest of your day and week. So
All
we'll
right.
see you next time.
Thanks all.